My name is Richard Proctor. I'm the General Manager of Global Healthcare and Life Sciences at Hortonworks. Today we're going to talk about business critical architecture for healthcare. So today's current data process with latent architecture in healthcare in particular has led to data being independent business processes. Everyone who deals with healthcare knows about the silos that have been prevalent over the past 20 years or so. And what this has led to is a lot of reactive reporting due to the fact that a lot of the information we're producing has been sent to a primary audience, which has been the government and regulatory agencies. And really the secondary audience has been internally and being able to use that data to improve care, quality, and efficiency inside the hospital systems. So what we're saying these days with modern data architecture with Hadoop is a complete opposite of that. We're seeing, because we have electronic medical records now, we're seeing data being entered into electronic systems, and we're seeing the byproducts of patient care allowing us to be more prospective and predictive with our analytics, with our primary audience becoming internally within our hospital system, provider, payer, or pharma company, and our secondary audience is really more the government agencies and regulatory agencies. So what we saw with our previous and current systems that many are still deployed with, very regulatory centric, repressive data silos, not many single sources of truth, and very expensive storage with very limited options. With Hadoop, we're seeing the ability to bring in unstructured, structured, semi-structured data, so all data types becoming more patient and organizational centric. Store everything is a mantra we hear very often because we don't really know what data will be valuable in 5 or 10 years. So the idea of storing everything inexpensively is really a better option for healthcare. So the current problem is that the architecture is under severe pressure, and a lot of that pressure is coming from the existing sources. The cost of storing data, the cost of bringing in emerging data together. Hadoop really turns that on its head by a new schema, a schemaless design, which allows for schema on read versus schema on write. And that gives us the ability to bring in data without having to tell the data exactly what it is. So what we're able to do now in healthcare and other industries is to bring in non-traditional data sources like unstructured documents, physician notes, emails, server log information, sentiment data, to see how the customers are looking at our website. Are they easily moving through our website, or are they getting confused and going somewhere else? We're also able to bring in clickstream data and geolocation data, and sensor data is very big now in healthcare. So the new data paradigm that's created with this schema on read and Hadoop is really going to separate the traditional, more laggard industries and players from the leaders. And we're really seeing that the leaders are going to be able to take advantage of the data that's now available in this schemaless form. So there's an enterprise blind spot where the winners are going to be that are able to combine more data sets, store and process data less expensively, and have more access to data over the coming years. So this is one of my favorite slides. This comes to us from Robert Wood Johnson Foundation, a very well-respected group. And this really looks at more around true population health management. So if we looked at, on the right-hand side, where the clinical care is 20%, if we took 100% of a human life, 50% being length of life and 50% being that quality of life, making up a whole person. The study at Robert Wood Johnson Foundation found that 20% of that effectiveness comes from the clinical care we receive, so our access to care and our quality of care. But that leaves 80% of the healthcare determinants outside of our actual healthcare delivery system. So healthcare behaviors like our diet and exercise, our alcohol and tobacco use, other things like social and economic factors like our income, employment, and our family and social support. And then our physical environment, the air and water quality, our travel times to work, things like that, actually add up to a greater number than the clinical care that we receive. So to truly look at population health and to improve our outcomes, we not only have to look at the individual, but we also look at small groups, larger groups, and then populations. We need to take in these other determinants to combine them to make up the 100% that gives us that more complete view of a patient, group, or population. So to take that one step further, healthcare has traditionally been a fairly laggard vertical. So we can learn from others that have been doing this for a lot longer than we have in healthcare. And the closest vertical to healthcare is probably retail. So if we take a retail approach, we've all heard of the 360-degree view of a patient or a customer. But the idea is to build these central data repositories where we can store and process all the longitudinal patient history from where they are, whether they're in the four walls of the hospital, whether in a clinic, a pharmacy, home health, specialty providers, short-term care, long-term care, wherever they are in the system, we should be able to track them, monitor them, and collect data on them. So when we have that data stored across the continuum, then we're able to build these 360-degree patient views and build predictive models around our high-cost, high-quality patients, which are usually our long-term chronic disease patients. So we can then take that data and have more timely impact on the patient, on a group, or on a population, and really detect things that are occurring outside the four walls of the hospital more rapidly. So let's look at some of the use cases, and we'll go in the sub-verticals, starting with the providers. This initial use case is around Mercy Health in St. Louis. They're an Epic shop, and they're one of the earliest Epic adopters and one of the largest infrastructures of Epic. They have 35 hospitals, 500 clinics, and 1 million patients annually. Their mantra was to have a one patient, one record. So wherever you turned up in the Mercy Health system, they should know who you are and be able to access documentation around your previous patient engagements with them. So their first and main objective was to improve their documentation. Their documentation was mainly on the coding side and the billing side. So they wanted to have documentation in a more timely fashion. So I'm going to go to an image that would show exactly what they did. So the idea was to take information from their Epic EMR system, and then they traditionally have an Oracle Clarity database. It could be SQL Server as well. But they have a batch process that takes that data from their Epic EMR to their Oracle Clarity data warehouse, and then into Portworx data platform. So the issue is that batch process across the top line here is a 24-hour period. And so it's a 24-hour wait to get the latest information on patients. So what they did was build a connector from Epic EMR directly into HDP. And they're now able to bring near real-time information about every 3 to 5 minutes from their Epic EMR into HDP, and then have applications, near real-time batch process applications read into those into that data while the patient's still in the hospital, hopefully. So improving their documentation, they were then able to improve their coding and have bed huddles with the physicians when there were questions around physician notes and other coding and billing questions. So they would be able to look at that data in a more timely fashion and interact with the care team to make sure they were getting a complete view of the care that was delivered to the patient. So they went a step further as well. So they built a connector back in to Epic. So when they update their clinical information and their coding, they're able to then put that data back into Epic so that anyone can access it at the bedside and have the latest and greatest information. Our next use case comes around something that UC Irvine really pioneered, and it was around historical and legacy systems data offload. So the issue is that UC Irvine had gone from an existing system that they'd had for 22 years. They had 1.2 million patient records, 1.2 million patients, sorry, about 9 million patient records over those 22 years. And the data on the legacy system was read-only. They looked at moving all that data into their new Cerner system, but the cost to move 22 years of patient history was cost prohibitive and not feasible at the time. And then there was the difficulty in combining data from the two systems. So what they did was they decided to move all their latent data information into HTTP and turn off the existing system as they moved this day forward in Cerner. So that's exactly what they did. And they found that they were able to move that over and then have existing system data from Cerner also brought in to the HTTP system and allow for a combination of data from the old system and the new system. They saved about $500,000 immediately in licensing fees, which would be an ongoing annual fee they would be paying. And they were able to then have two sides of the house, the clinical side of the house and the research side of the house, were able to dive into a centralized data lake with all their information saved for the last 22 years and then this day forward. We also have a customer, Zirmed. Zirmed was looking at a traditional data storage process versus having an HTTP process. And what they found was they were able to have 5 times the amount of usable storage plus 5 times the processing power for about 30% of the cost of the traditional technologies. So UC Irvine took that $500,000 in saved revenue, and one of their primary use cases they started with was around monitoring patient vitals in real time in the ICU. So a nurse rounds about every 15 minutes in the intensive care unit, and when she comes back or he comes back into the room, they typically take a reading for the time period they were out of the room. They found that that wasn't good enough to affect patient care in near real time. So what they decided to do was to stream patient vitals from their multiple systems through their sensor data into HTTP 24 hours, 7 days a week on those ICU patients. And what they found was that taking that sensor data, they were able to react much quicker to patient crashes and such. They're also able to, over time, be able to administer medicines, for example, to reduce patient temperature and to see how that affects the patient over time. So if a patient is a 33 to 45-year-old female whose temperature is elevated and they are given drug A versus drug B, eventually over time we should be able to have a little more predictive outcomes depending on which drug is administered. So let's look at a use case on the payer side as well. So one of our largest customers on the payer side was looking to have better visibility into claims data by marrying our claims data with clinical data. They have about 300,000 claims daily, and they needed to identify coding errors, duplicates, and overbilling. So the ability to bring in this data that's often disjointed makes it very difficult to identify these kind of undiscovered errors. So what they did was they were able to bring and marry the data together, use some advanced optical character recognition and some natural language processing to discover errors, and then really put more of a focus on those errors that were high cost to that organization. So I thought it'd be helpful if we put together an industry overview cheat sheet just to go through a few of the key targets and key personas that we would look for out in the field. So if we look at our target business personas, the CIO is obviously a very strong point of entry for us, but we're not always able to get in there. But we are looking for CIO. The Chief Medical Information Officer can be very influential as a kind of a conduit between IT and the physician. The Chief Data Officer is a title we're seeing now more prevalent in healthcare. So I think if they have a Chief Data Officer, that would be a good sign that they're a forward-thinking, data-driven organization. And then the traditional VP of Business Intelligence, Director of Data Management, and VP of Clinical Informatics are always also good entry points to bring in and try and get conversations with. If we look at our technology indicators and where we should really be looking, magnet hospitals and medical research facilities are very prevalent with us. We've had a lot of success. They typically have funding on the research side that the med-surg side can also dive into. We're typically not looking for the smaller hospitals or community hospitals, so multi-facility providers with 500 beds or more is a good target. And then forward-thinking younger CIOs, CMIOs, VP of Analytics is also a good target. Sometimes you'll run into a CIO that has just invested millions of dollars and is not open to investigating a new technology at this time. So targeting a younger organization is always good. And then someone who employs data scientists, statisticians, data architects is an excellent indicator that they're probably looking at something like Hadoop to supplement their existing data warehouse solution. Some of the industry priorities we see are they're trying to manage the paradigm shift and reimbursement models between meaningful use, pay for performance, and bundled payments. The changing rules of compliance associated with ARA and HIPAA, and then improving and managing the supply chain and labor costs, which tend to be the top 1 and 2 costs that the hospital would incur. And then expanding the effective capacity and care collaboration within the 4 walls of the hospital. So some of these are very common, as you know, and then when we get into gaining better visibility into high cost, high quality patients, and then population health mandates are definitely top of mind inside the payer and provider world. So let's look at some lessons learned, some of the conversations we can have with leaders in these organizations. So, you know, like it or not, most businesses are now running at the speed of the software that they run on. And Hadoop is absolutely a solution that is cutting edge and is something that providers, payers, pharma, and then industry players should be adopting and at least dabbling with at this time. So there's no question the Hadoop ecosystem is revolutionizing data management and analytics faster than any one company possibly can. The adoption curve. So we need to have our industry players start learning, adopting now, and be ready for full adoption as soon as they can to stay competitive amongst their peers. There is only one Hadoop licensed by the Apache Software Foundation. So they need to choose their distribution carefully to avoid vendor lock from proprietary solutions as they scale out.